Hello, doctor. This is the fifth video of my recall sharing from the recalls May 2025. And this video will have the question from the cardiology topics. So let's start. The first question is about ECG, given ECG. On clinical background, patients have a sudden onset of shortness of breath and chest discomfort, and systolic BP, most importantly, systolic BP was very low, less than 90, 85 that is, and it is a marker of shock or cardiovascular instability, and the ECG showing SVT. So this is a diagnosis of SVT with cardiovascular instability, a patient already in the state of shock. So what will you do next? It is a cardiological emergency. So will you go for cardioversion, that is electrical cardioversion, or antiarrhythmic medication, that is oral. We should go for emergency. In case of emergency situation, we go for a rapid management, that is the electrical cardioversion. So I think it is a not so hard question. The next question was a little bit of tricky question. It is previous one is easy, but next one is not so easy, I think. 55 years old male who is obese, a diabetic, a smoker, and businessman. That means a sedentary lifestyle. Hypertension not mentioned. Clinical feature, on clinical feature, patient have weakness and dyspnea. Thyroid function normal, and the ECG was given on the scenario, and the ECG was absolutely, there is feature of atrial fibrillation. So on this background history and with this ECG, the question is, what will you do? What will you do? So we will go with three scenario, actually, three option. These three options are all these are related with this scenario. Sadhas, cardiovascular risk assessment, and Hasbled scoring, we know. So with this scenario, for this particular scenario, which calculation or risk calculation is related most importantly? Sadhas is most importantly related, as because there is atrial fibrillation, and if it is non-valvular, then we will go for DOAC-NOAC, and if it is valvular, we will go for warfarin. So as echo finding was not there, so we don't know it is valvular or non-valvular. So for the sake of treatment of this patient with atrial fibrillation, we should go to start the treatment, and to start the treatment we need to do Sadhas scoring. This is the number one point of consideration, Sadhas scoring. Number two is cardiovascular risk assessment. As we know that after 45 years each and every individual should go under cardiovascular risk assessment. So it is another consideration. And the Hasbled, it is the bleeding tendency actually with those patients under anticoagulation. So these patients yet to start anticoagulation, not already under anticoagulation. So I think Hasbled is not related here, but the first two, Sadhas and CVT risk assessment, is most important here. So I think with this scenario, the Sadhas scoring is the most important. So what will you do? I will go for Sadhas scoring. So now we can go for the next question. Another question, ECG, and I think it is very easy. Just a hypertensive patient with hypertension, diabetes, and acute onset chest pain, and ECG given there, and it is just nothing but acute ST elevated AMI, acute ST elevated AMI, and inferior lead, that is a lead 2-3 AVF, and reciprocal changes on the other leads. So first question was easy or little bit easy. Second question was tricky, and the third question is easy. Now the fourth question. Older age patient I forget the actual age, but it is older, around 60 or 70. Patient have exertional dyspnea over the last few months or years, and having vertigo and poor concentration. These are the clinical features. Older patient having exertional dyspnea, vertigo, and poor concentration. One examination, there is ejection systolic murmur over the aortic area, just, and X-ray reveals. Actually, there is no image of X-ray or echo. It is the clinical feature given in the scenario that the X-ray having cardiomegaly, and the echo ejection fraction around 38%. So it is the ejection fraction is low on the background of cardiomegaly and ejection systolic murmur over the aortic area, and there is exertional dyspnea, vertigo. So it may be a case of aortic stenosis, aortic valve stenosis, evidenced by exertional dyspnea. Most importantly, uh, angina or chest pain should be there, but as far I recall from my memory, there is no inclusion of chest pain, or maybe chest pain there. Okay, whatever it is, but the vertigo and poor concentration, this means the poor circulation of the brain, and the essentially murmur over the aortic area, so it is the definitive finding, that's finding of aortic stenosis and cardiomegaly due to LVH, left ventricular hypertrophy on long-standing aortic stenosis, and ejection fraction 838. So this question is asking actually management protocol. Management protocol, either it is valve replacement or valvotomy. Is it valve replacement or valvotomy? My answer was valve replacement. Okay, so you can think again whether it is valve replacement or valvotomy. Next one, not so easy, I think. Feature of left ventricular failure, LVF, that is the defending edema present, shortness of breath, GBP raised, bilateral crepes, and oliguria. So the patient having left ventricular failure admitted through the emergency department and oxygen given, stat. Next step, what will you do in next step? Oxygen given. So next step, I was confused regarding two injection actually. All other three options are not so confusing. So is it injection morphine or injection fusimide? Just oxygen given, but no diuretics given on the scenario. So I think it is the answer is the injection fusimide. It is the first, not the morphine. Morphine of course needed for treatment of pulmonary edema, maybe due to left ventricular failure or not. So for the treatment of for the sake of pulmonary edema, morphine injection may be needed. But it is the case of LVF particularly. So injection fusimide should be given as soon as possible to decrease the volume. Okay, next. This is another question. Older patient, a smoker, dry cough at night, and X-ray was given on the image, and X-ray I took a few seconds more for this X-rays because on the X-ray I could not find out any abnormality, but I thought that why a normal X-ray given in such exam? Of course, something abnormal should be there, but I could not find out any abnormal, any lesion on the X-ray. So I think it is quite a normal X-ray. I think it is a quite normal X-ray. So on the background of a smoker history of smoking with dry cough at night and X-ray quite normal, the older patient. So what might be my diagnosis? My diagnosis may be bronchitis. These three are confusing. Bronchitis, bronchial asthma, emphysema. Absolutely, it was not a case of emphysema, as because X-ray is quite normal, not emphysema to change there. So emphysema not in our consideration. But the bronchial asthma, it is not. Actually, patient is smoker. So bronchial asthma may not be, but bronchitis may be, I think. So I put the answer as the bronchitis. The smoker with dry cough at night. Another one, a little bit tricky question it is. Clinical feature of lung carcinoma given is like chest pain, cough with sputum production, anaphylaxis, and most importantly, there is clubbing. Older patient, clubbing, uh, chest pain, and hemoptysis. X-ray was given in the image section, and there is a right side, there is lesion, a dense homogeneous lesion on the right mid zone, and it is uh, peripherally placed, that is uh, on the right lateral peripheral zone. So what investigation will you do next for this patient? X-ray already done. So what investigation will you do? Is it CT guided FNAC, bronchoscopy, or sputum microscopy? These three options were there. It's a tricky question, I think. So I went for the option CT guided FNAC, as because it is a peripheral lesion. It is a peripheral lesion. So anyone can think that we should go for sputum microscopy before going for definitive investigation. You may, but I went for the CT guided FNAC because the X-rays is there and next investigation. So next investigation, it should be CT guided FNAC or it should be sputum microscopy to see any malignant cell in the sputum. If we go for sputum microscopy, is it so much logical, or is it give me concrete evidence of malignancy? Though the question is not asking the definitive investigation, it is the next investigation after chest X-ray. So we can think it again and again whether it should be sputum microscopy or CT guided FNAC. But obviously it is not the bronchoscopy, as because the lesion is peripheral. In case of central lesion, we can go for bronchoscopy. So this is the last question of this video. Hope this video will helpful for those potential candidate for upcoming month of AMC MCQ exam. So thank you very much. If you any question or query, please put your valuable comment on the comment section of this video. Thank you.